Hello there. Good afternoon, everyone. I hope you're doing well today. Can't believe it's already the end of February. It is 3 o'clock, so I will go ahead and call our meeting to order. And while people are coming in, we will go over the goals of our Homeless Services Advisory Committee. I'll speak slowly to give people time to get in the room. Our goals are to finish the job of ending chronic homelessness, prevent and end veterans homelessness, prevent and end homelessness for families, youth, and children, and set a path to ending all types of homelessness. I will remind you that, of course, in this world of virtual that we've been in for so many years now, we know to stay on silent unless we're speaking. And I do ask also that if you have a question to please raise your virtual hand, and those who have their virtual hands raised will be recognized first. So we will do that just as a rule of order and out of respect for everyone else. I appreciate that. Thank you. Melissa, do we have anyone signed up for public comment?
We do not, Madam Chair.
Thank you. So then we will move on to approval of the minutes. Do we have a quorum yet? I'm guessing probably.
We do not just yet. I'll write to you in chat as soon as we do.
I appreciate that. And so we will skip the minutes for just a minute. I don't see Tarita here yet. So we will move past the policy and planning quarterly report. So that brings us to the city council wish list approval. So we'll go back and do the voting items once we have a quorum. For the city council wish list approval, the city council asked for 3 wish list items of wants and needs for the homeless community in Durham. A finalized plan will be submitted once approved by the HSAC, which again, we can't vote on this. So I apologize. We're going to just skip that. Forgive me. Let's skip on down to the next item. Oh my goodness. You think that I usually have my act together a little bit better than this today. In all honesty, I've been a little bit under the weather the last couple of days, so I'm sure you will give me grace. Has Tarita got here yet, or is Julia Gamble here? I don't see either of them yet. Okay. Well, then why don't, Russ is here? Did I see us? Yes, I did see Russ. Okay, yay. We're going to move on down to the point in time count. We're going to have to go back and catch up on some other things when more people get here. So we are down to the 2023 point in time count, and I will let Russ take over on that. Thank you.
And I'm actually going to shift it to a member of our team, Shante Addison, who's the Director of Client Services here at H&H.
Perfect, thank you.
Hi, everybody. So just wanted to briefly kind of review 2023 pit count. One of the points that we wanted to touch base on was how we identified known locations. This year we identified over 80 known locations where we suspected or have evidence of our homeless neighbors sleeping. In our street outreach team, they use known locations from what they're already working with. We've gotten reports from other community partners or other just members or citizens of the community. That's how we were able to identify those locations. Our street outreach team also went out prior to pit count to verify each location that there was evidence of someone sleeping there. Whether or not they were there the night of the pit count is a different story, but we did verify that it was at least 80 locations. We had I think we had 22 volunteer teams to go out to count the night of the pit count. Each team had at least 4 people on the team, including an officer or a heart team member. So we had 22 teams. The use of the Counting Us app, that was how we counted our unsheltered neighbors this year. We did that. We had 2 different surveys, one for if we actually conducted an interview, and a survey for if we only were able to do an observation. That went well. I don't think we have any outstanding interviews for Pitt. I think we've completed and verified, whether or not this was an incomplete interview or not. So we've done that. I do want to highlight that we had a record number of volunteers for Pitt Count. I think we only wanted about 70 to 80. We had over 120 plus volunteers this year. And many of them have already reached out the night of the Pitt Count asking if we would reach out to them for next year's Pitt Count. So we are super excited that we had at least 50% more volunteers than we requested, that we expected. So that was super exciting that we had so many people willing to come show up. We packed out the Durham Public Library, the main location. It was fully packed. Everybody was there and enthusiastic. That was super exciting. This was our first year using the library as our kind of hub, our starting point, and they have requested us to hopefully come back next year to do to be the center, the starting point for Pitt Count, our hub for Pitt Count, and they want to partner with us in other ways. And so that turned out to be a very meaningful relationship. We're really excited about that. We had involvement of local elected officials. The mayor came out, a commissioner came out. They both spoke at the Pitt Count that night. And they went out and actually counted unsheltered neighbors. They were paired up with one of our street outreach engagement specialists that night. And they stayed out the latest to count a number of people. So that was super exciting and enlightening for them as they reported upon their return. So I think this year Pitt Count was a great success. We're super excited to gear up for the actual numbers and see what those look like. I do know that there was an increase in families, increase in our Latino population. Of course, it rained that night, so some of the campsites we were not able to identify our neighbors, but we are working to confirm and just review the final numbers and to determine whether or not maybe they just shifted, and make sure we've counted as many people as possible and understanding the night of the Pitt Count. Not anymore, of course, but at the back end of Pitt, we did do that. We also did some service-based Pitt counts after the night of Pitt. So we went to UMD to do a meal count for those who participated in that meal, and we asked them where they slept the night of the 25th. We went to 2 libraries, South and Main Library, to ensure that we've captured as many people as possible so that we can have the most accurate Pitt count for this year. We mostly utilize staff for those service-based Pitt counts. We had a few volunteers for the main library location, but most of our volunteers showed up the night of the Pitt Count at the Durham Public Library. So we're super excited about that and excited to do it again next year.
Thank you, Shantae. Does anyone have any questions for Shantae? Okay. Wow, over 120 volunteers. That's amazing. Thank you so much for all the hard work that all of y'all did. You, Housing for New Hope, for sponsoring this. Those of everyone who volunteered that came out that night. I was unfortunately not able to be there myself. I really wanted to be, but I was not. I'm sorry, I'm smiling because Lloyd has his hand up, but it says Colin Davis, and I do know the difference. So Go ahead.
Good afternoon, everyone. Lloyd Schmeidler with the Community Development Department. I don't know if Colin wanted to make a comment as well. I particularly wanted to mention that the unsheltered count is certainly one of the kind of community-based effort to contribute to our point in time count for January 25th. The other primary component of our count is the sheltered count, which is largely conducted through our Homeless Management Information System, or HMIS. Most of our shelter and housing projects serving people experiencing homelessness with shelter do use the HMIS, but we are working to make sure we have good coverage for a couple of projects that do not use the HMIS. Certainly our domestic violence agency, the Crisis Response Center, is exempt from using the HMIS. So we're working on that end, as Shantae suggested, pulling together, finalizing our unsheltered count numbers as well, based on the surveys that the volunteers and staff entered into the county app. So certainly we at the department are very grateful that Housing for New Hope's team was able to organize unsheltered counts, the community outreach efforts, and we're grateful that it was as successful as it was. We will be publicizing, releasing the point in time count numbers as well as our housing inventory counts at the April 26th, what's the date? April 26th, 3 months from 2 months from now. We will present the official numbers. They're due to our federal partners at HUD by April 30th. So we will be presenting them at that time.
Thank you, Lloyd. And again, thank you for everyone, all the hard work that went into this. Obviously, a lot of coordination, a lot of things that happened. So we appreciate that very much. Looking forward to hearing those numbers and see what we can do to make them smaller next year. That would be great. We do have a quorum now, so we will go back to approval of our minutes. You should have received the minutes. The HSAC members should have received minutes in email. I think it came out on Monday, but anyway, this week. Hopefully you've had a chance to look at them. So at this time, I will take a motion to approve the minutes for January 2023.
I'll make a
Angela Holmes made a motion to
motion to
approve.
approve the minutes.
Thank you. Do we have a second?
I'll second. This is Eliza Matthew.
Thank you, Eliza. Now, in the chat, HSAC members, yes for approving, no if you do not approve, or abstain if you need to abstain. It looks to me like we have a bunch, I don't see anything but yeses, so I'm going to assume at this point that means that it is passed. All right. I don't see Charita here yet. Is that right? Okay. Well, then we will move down to the City Council wish list approval. As I was saying, and then realized that this is a voting item and had to stop. City Council asked us for the 3 wish lists, and we will submit a finalized plan once the HSAC approves it. The wish list includes additional supportive services staff, flexible housing subsidies, additional affordable housing, and non-congregate shelter that would meet a variety of service needs. So I'm going to get, Colin is the one, are you the one that's going to talk about that? Well, then you can, okay. Sorry, I was reading a note in the chat. So Colin, you got the floor.
All right, good afternoon. As you recall, at our January meeting, we discussed a wish list items and we talked it through, did surveys, staff compiled all that information, kind of came up with some themes. We then sent out an invite to the full COC on February 1st and had a discussion to try and land on what 3 or 4 items would be. And we've landed on, there were some common themes that were coming through: supportive services, flexible housing vouchers or additional housing vouchers, additional affordable housing, and non-congregate shelter. So we went back and we were able to put some dollar amounts that would translate into specific numbers of people. And we came up with, if we requested 45 additional support workers, which would be 45 full-time equivalents, it would be a mix of supervisors, case managers, home health aides, SOAR workers, anybody that would take to help keep people housed and support people in their transition from homelessness to permanent housing. Averaging that out at, not that the city would be able, and county would be able to cover 100% of things, but $2.75 million. It would work out to just over $61,000 per position, loaded salaries, things like that. So it'd have to, somewhere between 30 and 45 support workers is where that would come in. If you did the 45, you'd be at about that 61,000 average per person. Looking at flexible housing vouchers, there was a request for that. And we know that housing vouchers are dedicated and dictated by HUD. And those are allocated to the housing authority and they have to issue them. Part of our challenge is, well, HUD doesn't always increase tons of extra money into the voucher system. So looking at it is, do we need more rapid rehousing? Do we need more PSH? Do we need more housing vouchers? The answer is yes, yes, and yes. So we looked at it and said, maybe we should consider this a locally funded flexible housing voucher, that these could be used as short-term, i.e. longer than 2 years, but shorter than for the rest of your life. And some that may be eligible for that longer than 2 years, and possibly after rapid rehousing ends, somebody could transition into a flexible housing voucher, for lack of a better term, for another 2, 3, 4, 5 years, and then be able to transition off of it and recycle it. There may be some people who need a housing choice voucher, and there's not enough permanent supportive housing placements or housing vouchers or public housing options. We may need a small number of that. So that got enumerated to $2 million. And rough estimate would be $1,000 per month per household subsidy. It may not cover 100%, but if you assumed $1,000 a month subsidy, that would make a pretty big impact. It may go up. You know, if we did 1,500, it would reduce it. But at $1,000 a month subsidy per year, you'd be looking at helping an additional 100 households. It would go up to probably 150, 160, but we have to be careful when you're using flexible housing vouchers that over time, that voucher is going to have to get deeper as rents go up. So we can't just go give 166 vouchers if that dollar amount wouldn't be sustainable. The other piece was looking at affordable housing. And I know we've talked about the need for permanent supportive housing. The cost, the current total development cost of developing a new unit is $325,000 per unit. So just for simple math's sake, let's assume we wanted 100 affordable housing units. You'd be looking at $32,500,000 as a total investment to acquire land, site development, design, and build a 100-unit structure is what the current average rates are, according to the folks on the multifamily team. The fourth item was a non-congregate shelter that would include space for medical respite, white flag, overflow, a day center where supportive services, street outreach would be able to operate out of, and people would be able to have a place to come. Unsheltered individuals would be able to have a place to come and shower and do laundry and connect with service providers as needed. So that's where this list is at this point. And the question for the group is whether or not the HSAC would like to adopt and approve this wish list being submitted to city council and county commissioners during the budget season? If the answer to that is a yes, we will draft a letter that the chair of the HSAC, Helen Tripp, will sign. And that letter would be sent to the mayor, city manager, and the chair of county commissioners and the county manager, so that they have it in their records as they're working in what is commonly termed as budget season. Questions?
Ryan?
Colin, I'm just wondering, there's so much talk about Medicaid expansion right now, and granted, it hasn't happened yet, and it's been almost 8 years, but my understanding is that with the housing opportunity pilots, that many services and tenancy supports, would potentially be eligible, with Medicaid expansion. Is there, any, I guess, reason to potentially wait and see if that happens before making a recommendation that would potentially include a significant amount of money for services? Because I'm not sure we'd need to do that if Medicaid expands.
Well, I think you raise a good point, Ryan. I guess you have to look at two options. One, you wait, and we can wait and see what happens with Medicaid expansion. We may not have an answer on that until May or June, and at that point, we've missed the boat. We delay all of this a year. The other side is we put in the request. Best case scenario is city council and county commissioners say, sure, yeah, here's the money. And then Medicaid expansion comes through. We could scale back or, have a conversation about how those dollars could be used in other ways if there's another funding source. And keep in mind that Medicaid expansion, even if you expand Medicaid, we have a lot of people in the homeless system who don't currently qualify and may not qualify even under the expanded rules for some of those services. There's always going to be a need for probably some additional supportive services throughout the system that Medicaid may not be able to hit. And you've got to have the appropriate staffing and reimbursement structures. I'm not an expert on the MCO process, but I'm sure there's others here who know way more about that than I do. So I think there's gonna be room for it. And like you said, we could wait. It would just delay. We'd have to go back a year from now in the next budget cycle if Medicaid expansion doesn't happen.
And to me, I guess I'd suggest that maybe just some qualifying language around the services proposal that, if Medicaid expands, that this might look very different, or that we could shift resources to other priorities.
Good suggestion.
Thank you, Ryan. Drew Wooten?
Colin, I know you put a dollar amount on the supportive services and on the housing vouchers. Was there a dollar amount for the non-congregate project?
I did not get into that because that's a totally different ballpark. I mean, that's a combination probably of all of it, essentially. I mean, you're talking about the staffing, and there's some of that money is already in the system. These are totally new that are not allocated in the system. So I know there is a lot of discussion about about shelter redevelopment going on and some planning on that. So the thought was to make sure that we put it on the radar. The last dollar numbers I've heard, and I don't know if Sheldon's here, but I think I know Russ was here. Yeah, Sheldon's here. Sheldon, I think the proposed shelter redevelopment was in the $40 or $60 million range. Is that correct?
Yeah, Colin. So we're looking at 40 to 60, depending upon the makeup of the different partners that might be involved in that.
So we can put the full 40 to 60, we could put the $40 to $60 million request in there, that it's a wish list, but it's kind of, this is the HSAC's opportunity to put it on the radar that these are our wishes. It's like the proverbial Christmas list. You don't know what Santa will bring, but you're gonna put it out there and let people know these are the things that the group identified as needed. I see a comment, Russ. These are we did not rank these as any particular thing. We started with the supportive services piece and the flexible vouchers, only because they were the easiest ones to put a dollar amount on. 30 to 45 staff members, that's easy to calculate. Flexible housing vouchers, relatively easy to calculate. And then it just sort of went bigger. So it was kind of, we need it all. Obviously, if you decided to do tons of construction for this population, it will have to have the supportive services. So they're kind of tied together, and sort of, you don't really want to build something without a plan to ensure you've got the appropriate staff levels to support people in those units. Does that answer your question, Russ? If the HSAC would like to, could choose to prioritize one or more of these. Our staff was thinking through the process of what could make an impact as quickly as possible. And that's kind of where we started with if you have more supportive services people, we may have people maintaining housing longer. So that was an immediate, here's some money, we can immediately hire people, versus we have a need, here's $40 million, and 5 years from now, we'll have a building. So that's kind of how we also looked at it. Commissioner Carter.
Yes, thank you. I'm really happy to have this list. I'm so glad the city council asked for it. It's a wonderful request. And I think it's a fantastic list. Will you all, if the HSAC votes to send this forward, will you be including explanatory notes for commissioners and council members? So we'll have a full understanding of what each of these are.
That's the plan, is to try and put a little bit of a summary of what this entails and a logic behind it.
Great.
Thank you.
Sounds good. Thank you.
Mhm.
Are there any other questions? Okay. Well, if not, then I will accept a motion to accept this wish list for additional supportive services staffing, flexible housing subsidies, additional affordable housing, and non-congregate shelter as the priorities. So moved. Motion by Natalie Becker.
Second.
Second by Angela Holmes. Thank you. So in the chat, HSAC members vote yes if you approve, no if you do not approve, and abstain if you must abstain. All I'm seeing right now are yeses. It appears that we have approved this motion. Russ.
Sorry, just a really quick question that I think probably got lost in the chat with all the yeses. Who's going to write the explanations? Is that something staff's doing, or does exec or planning and policy one of the other groups need to be involved in helping articulate that alongside you?
Yeah, we can run it through exec committee.
Okay.
Well, staff will draft it and work with the executive committee to tweak before it gets finalized and signed.
Okay.
Thank you. Good question. Okay, the motion has passed. Thank you for your votes on that. Thank you, Colin, for the explanation, and for everybody for all the hard work on getting that list together. Okay. Colin, are you able to do the policy and planning quarterly update in Sharita's absence?
I can do my best, yes.
That's all I can ask.
So over the last quarter, we have been working on the wish list, working on what our plans, we've started talking through the plans of the closing of the non-congregate shelter, which will be happening in June 30th of this year, and how we're going to absorb people back into the system. At what point are we going to cease accepting referrals into the non-congregate shelter? We're going to have to start talking about the home ARP. We've been working on that as well. So a lot of it's just been looking at this really high level stuff and putting back on, well, we've put back on the radar our ESG-CV, some work on our ESG-CV monitorings, which we'll talk about later in this meeting.
Thank you, Colin. And next on our agenda is a medical respite presentation, and I have as the lead for that Julia Gamble.
Hey, yeah, thank you. So I've got a PowerPoint that I'm going to share. So let me get that going. Let's see if I can do it. There it is. And I'm going to do my slideshow. All right, if you can't hear me, let me know, but I'm going to go ahead and get started. I know we don't have a ton of time. So this is an anniversary moment for us. February is a big month, and 2013 was the starting place for it. So it's been 10 years. And I want to dedicate the presentation to the men and women experiencing homelessness who helped us know we needed it and who taught us how to start doing it. So medical respite is a thing that's happening all across the United States. It's been going on for a long time. And it's essentially a short-term placement for people who are experiencing homelessness who've had a recent issue and have an ongoing medical need. The idea is that they're stabilized, they heal, it's a safe location, and they access supportive medical and other services. The settings vary. Some are in shelters, some are in freestanding buildings, others nursing homes, transitional housing, etc. And the funding is frequently from hospitals, a lot from private donations and local and state governments, and most of them have multiple funders. There's a National Institute for Medical Respite Care, and it maintains a directory of programs and standards. So our program is called Durham Homeless Care Transitions. And what happened was, we realized there was this need based on our experiences as individuals serving folks who had homelessness and medical problems. At the time, I was at Lincoln Healthcare for the Homeless Clinic as the lead clinician and manager. We had a colleague named Stephanie Williams, many of you may remember at Alliance. We worked really closely with Terry at Housing for New Hope and Sharon Elliott Bynum, RIP, at Healing with Care. We had folks from North Carolina Coalition and Homelessness, Emily Carmody, and of course, Sally at Project Access and our partners at Duke. We began meeting, and really, frankly, the meetings came out of our experiences with patients. We went to the Access to Care Committee of Partnership for a Healthy Durham. Some of us were members, Sally and myself, and we advocated for considering medical respite as an access to care issue. That explicitly came out of the experience of a person who could not get surgery for more than a year because she didn't have a safe place to recover. The partnership endorsed it in 2013. We then got grant funding to host a community roundtable. Some of you may have attended on Valentine's Day in 2013 with presenters from the Boston Healthcare for the Homeless program. They've got an amazing respite, and the National Healthcare for the Homeless Council. And what we realized was that hospitalizations can provide an opportunity for connection and engagement for folks who previously may have been poorly connected. And then this body, the HSAC, endorsed our presentation around a medical respite pilot program in the fall of 2013. And a letter went to City Council and the County Commissioners in January of 2014, encouraging funding. So our program has been ongoing since 2014. We're a recognized program, one of 4 in North Carolina by the Medical Respite Credentialing Agency. We follow a scattered site model. We don't have a building. We use locations where we can lease beds for our clients. And in addition to a location for healing, we try to do a lot of work around connection. I think connection is our real mantra of what we do. So that includes primary care, specialty care, behavioral health, substance abuse services. We engage home health care as needed for our clients. We help with benefits acquisition, transportation, improved social supports, and improved housing. So our logo is there, and you can see it's a bridge. We're, again, all about connections. We're part of Project Access of Durham County. Project Access is a nonprofit that has, multiple things it does, and some of them are things that you all might even use. For example, the Health Equipment Loan Program. The leadership team is Sally, who is Executive Director of Project Access. I'm the Clinical Director, and our Research Director is Dr. Donna Biederman from the School of Nursing. And then we've got a staff with a nurse care manager and a housing specialist. So who do we admit? Well, they've got to have something going on that's acutely new or worsening, and they need a short-term stabilization. They need to be single. We don't work with families. They're referred by some type of medical entity, hospital, clinic, crisis facility out of Durham. And they'd be going home if they had a home. They're able to participate and maintain in our program and maintain a safe and harm-free environment, and follow applicable rules of the locations we place them in. They are willing to participate in case management visits and competent in what's called activities of daily living. So that means taking their own meds, preparing food, doing laundry, that kind of thing. They're psychiatrically stable. They could have mental illness, and many do, but they need to be stable. And here's a side note. Lots of homeless people are medically vulnerable, maybe elderly, but they don't necessarily require respite. So we do a lot of work around diversion and consultation. So that would be a situation where we get referrals from hospitals or clinics, or maybe some of you, for persons not qualifying for medical respite, and they're not really appropriate for the shelter. And we work hard on creating diversion opportunities that are safe for those individuals. A lot of work on placement advice. So that could be a higher level of care, like a family care home or assisted living. And if an individual needs a short-term skilled nursing stay, so that might be a location where they're getting IV antibiotics for 6 weeks, and then after that, they could go back home again. The skilled nursing facility may not take them if they're homeless in the hospital, but our team will then work with the hospital to tell the skilled nursing facility that we'll accept the individual on discharge, allowing the individual then to get the necessary care and then return safely to our community. We provide advice on resources in the county of origin. Many individuals may be from another county, and assistance with return if appropriate. We talk a lot about adult protective services, and we have a real strong relationship with the county APS system. And we give advice on Alliance and the services available there, including care coordination services. So our pilot program, in 2014 to 2016, with the help of HSAC and the Partnership for a Healthy Durham, we were able to say, hello, city, county, we would love some support, and this is our pilot program. And the County Department of Public Health provided $15,000 for medical shelter costs for our clients, and we provided in-kind support. Our pilot program served 29 people. And we were able to show some, I think, good outcomes for a complicated population. We newly connected a good third of people to behavioral health services and a quarter to newly connected to primary care. Individuals got Medicaid and income, and a third improved their housing status. So we took those results and we applied for a grant from the Helen Innovation and Care Award. And that's a grant that is really targeting nursing innovation. And Dr. Biederman and I are both nurses by training, and that's what got us that award. So with their funding in 2016 to 2019, we continued our work with ongoing support from the county at the same level, as well as creative collaboration with our partners. And specifically, I want to give a shout out to Alliance Behavioral Health, who's been an amazing partner throughout. We continued our focus on medical respite and medical case management. And Dr. Biederman worked on an evaluation study that was published in 2022 that compared 497 of the referrals we got in this time frame with 125 of the enrollees. So each of those 497 referrals had the opportunity for extensive medical chart review, case consultations, and diversion assistance. And the folks that didn't enroll, you know, some of them we couldn't reach, some didn't have a medical need, some said no thank you, some weren't homeless, and some needed a higher level of care. So of the folks that did enroll, that 125, we found that the folks that enrolled with us were 3/4 male, average 51, 68% Black. They had significant medical illness, as well as substance use disorder and mental illness. And a good half of them had something called trimorbidity, which means they had all three: medical, mental health, and substance abuse disorder. And that's not a surprise to those of you on the call who work with our patients. Our outcomes for this group of 125 in that time frame are here. And you'll see the connection that we really worked on, this trying hard to get folks strongly connected to their medical home and specialty care, mental health services, substance abuse treatment, continued. We worked on improving their housing arrangements and enhancing access to income and insurance. So the key findings in the study that were published that y'all can look up, it's available, and I'm happy to share with you, is that again, the folks that were accepted into our program when compared to the others that weren't accepted, they were sicker than the group that didn't enroll. They had the trimorbidity issue. They were as likely to have substance abuse disorder as the folks that didn't enroll. And the folks with substance abuse disorder had comparable outcomes to those who did not. That's important to us. And I just want to really stress that we're not a substance abuse program. We're not a substance use program, but we serve folks with substance use disorder, and it seems like we're doing a good job. Our outcomes were similar across racial and ethnic categories. And then, statistically significant improvements in healthcare use. We shifted individuals in looking at their 6 months prior and then their time with us to using outpatient care. And they had decreased ED visits and hospital days. Okay, and then now the present, looking at some of our HMIS data, this has not been part of the study. This is 2020 to 2022, end of 2022. In the respite program, you can see our numbers. And then we had this exciting opportunity of non-congregate shelter with the Carolina Duke Inn. We had some beds there. And you can see the services provided and our outcomes. I think it's probably worth just, again, highlighting the age is still about the same. You'll notice that the referrals from the hospital were higher among the respite group. We had a slightly longer median length of stay at Carolina Duke Inn, but in terms of exits to housing and income and insurance, sort of similar. We found we served a few more women in the non-congregate shelter. You'll notice that as well. And I think, that concept of sort of the longer term private room might have been a benefit there. So then there was COVID. Do you guys remember that? Yeah. So for 2020 to 2023, our team assisted the city and county with the homeless COVID response. And so we provided 147 persons experiencing homelessness with isolation housing during their isolation time. And for homeless individuals, it's about a 10-day, it was 14 and then moved to 10 days. Course, and with food, laundry services, medical assessments, both telephonically and in person, and pharmacy support, and housing discharge and planning around that. Our partners referred about 7 days a week to us, and they came from our main hospitals, including the VA and our shelters. Families Moving Forward participated with us until they began doing their own COVID isolation process. We had a number of referrals from Open Tables, White Flag at Trinity, not so much this year, but when they were at Trinity Entry Point, and then the county Department of Public Health's COVID hotline when that was working. We had a whole bunch of referrals not included in this 147 that were consultations and diversions. So some people, for example, that I found too sick and ended up recommending the hospital place, and they did, in assisted livings or skilled nursing, and other individuals who were able to return with some supports to their prior setting. These are the 8 peer-reviewed articles that we've published with Dr. Biederman as the lead author. And I'll just call out that article in the Journal of Healthcare for the Poor and Underserved in 2022 that our data came from that I shared earlier. So why does it matter? I just want to kind of go back to 2013. We shared a story of somebody who was one of our patients who had emergency surgery. She was at Urban Ministries. She was returned to the shelter post-surgery with a wound that she was, told how to care for. Less than a month later, she went back because of an infection, and that required another surgery, and she was left with a larger wound. The wound team at the hospital recommended a machine called a wound vac for about a month to speed up healing. She didn't have insurance, but there was a program that would have given her one for free. But they said, we can't do that at the shelter. There's a high risk of infection and contamination there. So she didn't get one. And a year later, Denise still had a wound measured at 7 centimeters deep in her abdomen, frankly, because of a lack of care. And that takes us back to the access to care problem that we talked about with the Partnership for a Healthy Durham in 2013. So in 2022, fast forward, 2 different individuals, one a man and one a woman, had surgery, were given wound vacs and provided with respite housing assistance. They also had home health services. One of them was indigent and the other through their insurance. They had case management through our program, and with our assistance, close connection to specialty care and mental health services. One of them is now in housing through rapid rehousing and on DHA wait lists. And one of them is in a DHA unit with TCLI support, and their wounds are healed. I'll just go on and talk a little bit, if it's okay, about diversion and why it matters. The first little case study I've got here is from an individual who's touched many of the programs on this call. He's a chronically homeless gentleman with worsening health conditions who was referred repeatedly to our program. And frankly, we assisted him 3 separate times, one of them in COVID isolation. Unfortunately, he failed independent living and on the streets was at risk of death. He had multiple episodes of stolen funds because he was taken advantage of. So during hospitalizations, and there were many, we requested the hospital to provide brief cognitive testing. And what we found was that he had worsening dementia each time. So we coordinated with APS regarding self-neglect. And he now has a guardian, lives in a care home, and is participating in medical care. And he tells me he's very, very happy. And the next narrative is a case that we were involved with who had multiple illnesses and Medicaid and primary care and mental health services in another county, actually multiple counties away. That crisis center in that county took the easy way out. And when she presented to the crisis center homeless, put her in a cab and spent a lot of money to send her to the Durham Rescue Mission because it's easy. And she immediately was hospitalized in Durham. Our team got the referral and we coordinated with her home county mental health system, that LME, which is distinct from Alliance, and the primary care physician in her home county to arrange follow-up. And we assisted with first month's rent and housing there with a plan for her to take over the rent with her SSI income. So those are 2 clients that we worked on diversion for. So what have we learned? Well, it takes a village, collaboration with multiple community partners, and back in the 2013 timeframe and ongoing has been important. We're really grateful for our partnerships with the discharge planners at the hospitals, with Alliance Behavioral Health and its many affiliates. And I just want to again give a Alliance shout out. I know our ILI coordinators on the call, and thank you for all the work you do. And thanks to Alliance for the health and housing pilot they've collaborated with us on. And I know, Malcolm, you're on the call, and the DASH voucher has been important. So thank you, Alliance, for all the work you do. And then our community agencies who provide homeless and housing services. You all are amazing. And we are on speed dial every day with each of you. We'd also learned that health events are a moment of great stress, but they're also a moment of intervention. They can lead to healing, and they can lead to the end of homelessness. And then lastly, finding funding can be hard and requires multiple sources. We'd love to have more funding. If anybody has ideas on that, we're welcome to talk more. And then I'm open for questions, and I really appreciate the time. Thank you.
Thank you, Julia, for the amazing work that y'all are doing and the impact you're making on the community.
Thank you so much, Helen. And gosh, did I give a shout out to community paramedics? I didn't, but let me do it right now. Woo! You guys are amazing. You're on speed dial. You are.
Oh, absolutely. You're on mine too. Brian.
Congrats, Julia, to you and Sally. I just wanted to circle back around on one of the stories. Did I understand correctly that being in the shelter might disqualify someone for indigent care? That's shocking to me.
I think that's maybe a yes and a no. Can I talk about that more? Is that okay? It's the type of indigent care, right? So this person, it was deemed to be an unsafe setting to have a wound vac, too much potential risk for infection. Right. So less about the shelter and just more about the fact that they wanted to take really good care of that wound and make sure that that was a safe place for the person to be having their wound care with that machine in. Yeah. Yeah. So homelessness in and of itself, so just building on this, Ryan, could I tell you some stories? I could. I know my time is limited. So let's ask a question. Can the hospice provide services in a tent? Carolyn Schultz from Open Table knows they can't, they won't. And that was one of the genesis stories with our program. So back in 2013, we had a client who needed hospice services. And he declined accessing the shelter, and he was in his tent, and we needed him to have hospice care, and hospice refused to visit the tent. So mountains were moved, places were found, we struggled, we did it. And we realized what we were building was respite, right? And so I need to say that some locations, entities have concerns about serving individuals in, and it's a lot about safety. And it's a lot about trying to do the right thing. And so we have tried to build something where individuals can get the care they need.
Thank you, Julia. Thank you, Sally, and everyone else is doing just amazing work. Anyone else have any questions? Commissioner Carter.
I do. This is couldn't find the raise my hand button, so I just did it manually.
I saw you.
Thank you so much, Julia, for this presentation. I have known for a while that you and Sally do superstar, amazing work in our community. I didn't understand the history, though, of the Durham Homeless Care Transitions Program, and I'm really glad to know that history. And I think it makes such a compelling case. The history combined with your stories, combined with the data that you all have collected and published, over this time period, it makes a compelling story for expansion of what you're doing and additional resources being provided for you so you can do more work, especially coupled with the fact that, I've heard from the hospital, from Duke Regional Hospital, that their length of time metric, they're exceeding their benchmark there by a lot, partly because they have stable people, but they have nowhere to exit them to, so they end up staying in the hospital longer. It just seems like maybe the hospitals would also be interested in expanding a program, because then there would be more receiving spaces for discharge. But I guess my one question really is, has the county expanded funding for you all since the beginning? Are we giving more than $15,000 to you all now?
Yeah, I'm going to defer to Sally on that one, because I'm not the money one. I'm the clinical one. Sally, what's our answer there?
No, but they have continued with the ongoing 15,000. We appreciate.
So yeah,
Sure.
we certainly don't want to complain, but boy could we use more.
let's talk. I think that, you know, like I said, there's a very compelling case that the work you're doing is effective and efficient and that we need more of it. So I'd like to talk more if we could.
Thank you, Commissioner Carter.
I'll reach out to you guys, okay?
Thank you.
Any other questions? Okay. Well, again, thank you, Julia, for your presentation. And again, for the work that you and Sally and the rest of your team are doing. We certainly support you continuing that as we move forward. And I'm still going to keep you on speed dial. Don't worry. Okay, we're going to move on to our next agenda item, which is the ESG CV monitoring. And I will let Colin talk about that and explain it.
All right. Good afternoon again. Colin Davis with Community Development. Go over our ESG CV monitoring report. Let me see if I can pull this up. And let's go to the beginning here. There we go. All right. So, whoops, wrong report. On the right one. There we go. Let's get the right report. All right. You see the screen. We'll go through this. The U.S. Department of Housing and Urban Development, HUD, their headquarter office, monitored the city of Durham for our ESG CV funds. Began in September of 2022, and we did not receive a monitoring letter until December 21st or 22nd of 2022. The letter was dated the 21st. The monitoring focused, one, on overall city of Durham doing what we need to do, and then they chose, out of all the eligible activities that we funded with our ESG CV funds, which were prevention, rapid rehousing, and emergency shelter, they chose to focus their monitoring on our homeless prevention projects. Keep in mind, homeless prevention is quite possibly one of the most difficult and challenging and nuanced programs in the ESG catalog of eligible expenses. And they did say, they commended us for standing up one of the hardest programs to get up and running during a time of COVID crisis. And they understood that we did it to try and meet a community need. And we did do a good job of doing that. With that being said, we did have 7 findings. So this is just to kind of go through and give you as the HSAC an idea of what these 7 findings are and what our next steps are. So the first finding is the city failed to ensure the subrecipients documented all aspects of their homeless eligibility. The case files that HUD reviewed, and we uploaded probably over 50 case files, did not contain evidence of staff looking at every individual's lack of sufficient resources. With prevention and rapid rehousing, it's critical that you must demonstrate without these funds, the person will be homeless. And that's where this finding is really targeting to, is we did not have staff. There was not a process of calling and verifying and a checklist that was used to say, yes, called all family, friends, verified, there are no other funding sources for these folks. Second finding was that the city failed to ensure the subrecipients either adhered to the established standard operating procedures and written standards, or failed to maintain updated policies and procedures for the ESG CV program operations. While the standard operating procedures have been deployed by the city and several subrecipients, the standard operating procedures do not outline the process steps for meeting the program requirements, nor do records confirm subrecipients adhered to those established, but rather highlight inconsistencies with staff using various forms of ESG, the COC program, and those established for ESG CV. The city did not properly train nor monitor subrecipients related to the policy requirements. So we do have a multitude of forms being used by subrecipients, some state ESG, some COC forms. At the end of the day, most of those forms collect the same required data elements. There was not consistency in it, and there were some policies and procedures where the city's written standards said one thing, but agencies, policies, and procedures had something different, or the city's the city standards may have been different from what the federal regulations were, and there wasn't enough clarity of what that difference and why. Finding number 3, the city failed to complete or update information on all ESG in the IDIS. This is an easy fix for us. This is the IDIS is a government database where we have to upload information into how much money is going into an ESG CV project, and specifically what is this money being used to do. And that we did front some city money for ESG CV expenses. That was the first year we did non-congregate white flag. So we didn't clearly articulate that enough in a database. It's clearly articulated in all of our grant agreements and our contracts, but in the federal database, we have to go in and just update the language in there. That's what this finding is about. Finding 4, the city failed to exercise appropriate oversight and monitor its subrecipients for program compliance. Though the city shared with HUD an established compliance monitoring plan that includes a monitoring strategy and tentative dates for reviews, the city failed to conduct any annual compliance monitoring reviews to ensure that the program was being run in compliance with ESG CV program requirements. The city did do program monitoring on all expenses that were coming in. We did not do programmatic file reviews, as our compliance manager resigned to take another job during the pandemic, and we didn't have capacity to do monitoring. The other piece is the prevention projects recently hit their 1-year monitoring mark. So we hadn't even had the projects up and running for 12 months. So we hadn't gotten to an annual monitoring yet. The city, it's finding number 5. We failed to conduct and maintain required re-evaluation of participants' housing and service needs, sufficient resources and support networks, and where the annual income exceeds the very low income limit to ensure adjustment is necessary. This is one of those things where the federal regulations state that you must review this at least every 6 months. Our written standards require every 3 months. There were nobody in any of there might have been 3 people, if I remember correctly, and if VOA is on the call or open table, you can correct me. There was fewer than a handful off the top of my head, participants who were in the prevention program for longer than 6 months. So some of this is really not applicable, but we didn't have a standard form that was being used, and people who had been in there according to our COC written standards of a 3-month evaluation did not have that in the files. Finding number 6, we failed to ensure adherence to rental assistance agreement requirements with sufficient evidence it entered into rental assistance agreement with the owner. So this is basically our subrecipients when there's a lease in place and a subrecipient, i.e. nonprofit partner, is going to pay a landlord on behalf of somebody. There is a second document which is entered into. It's not a lease, but it's another document that says agency A will pay X number of dollars for X number of months for these things. In exchange for this, here's what the landlord has to do. If the landlord has any problems, the landlord must notify the tenant and us as the third party involved of issues, and we have to stand that up. We did not have a standard form that was being used. Some of these were done via letter, some of these were being done via email. There was not a specific contract with everybody signing on it. Finding number 7, the city and its subrecipients failed to conduct and document that the program participant met with a case manager to establish a long-term housing plan. This is one of the requirements of both prevention and rapid rehousing, and it's essentially work on that in shelter as well, but creating stability plans. And we do not have a standard housing plan form in our continuum. There were notes in the files about people talking about housing and plans, but there was not an official document that said housing plan, and here are the steps that took into consideration all of the funding sources and income potential and public benefits that people may apply for to be able to figure out how to sustain their housing after the ESGCV funding ended. So those were our findings. Good news is, as of right now, none of these are going to require funds to be paid back. We did have a 60-day time frame to respond to HUD, which we did. We responded to HUD in writing. And we are going to need to work with the HSAC and the continuum of care and the providers to develop new standard forms that everybody will be using for prevention, rapid rehousing, emergency shelter, so that we'll get rid of the piecemeal approach that we've been operating in. And we will need to update any and clarify any of our standard operating procedures, written standards, and do a whole lot of trainings to ensure everybody has the trainings to do these in compliance with federal, state, and local regulations. City also has to go out and do monitorings of all of these projects. And we are currently working with HUD. We submitted a letter to HUD with a proposed timeline, and HUD has requested that we chat with them to kind of come up with what a fair and reasonable timeline is to get these things done. So we did want to put this on the HSAC's radar, since these were findings that did come to us, and let you be aware of it. And I'll take questions if anybody has any.
Thank you, Colin. Does anyone have questions for Colin?
Excuse me, this is Tracy. Was this the first monitoring or compliance meeting or review the city has had in maybe a couple of years?
Well, for ESGCV, yes. I mean, we got monitored 2 years ago for our CO. It was the city's continuum of care, the planning grant the city received. So it'd be just a project sponsor. This was the first time that HUD looked at the homeless system in this way for these particular funds.
Okay, thank you.
Mm-hmm.
Sally?
Oh, did I hear you say that standard forms are coming for rapid rehousing too?
Yes, and some of that is because prevention and rapid rehousing have a lot of similar rules and regulations that overlap. So while these findings were specifically focused on the prevention program that we no longer have, we're thinking we need to just sort of be consistent on this, because we've been sort of allowing people to use forms that collect the data that's required and work it into their agency workflows, agency business practices.
I'm looking forward to it. Thank you.
Mm-hmm.
Ryan asked, do any of the concerns raise a red flag related to possible findings in the traditional ESG program?
Some of those, like I said, those forms where we have agencies that have COC rapid rehousing, state rapid rehousing, and city ESG rapid rehousing. We do have all three of those have different forms, and in our continuum, people are using one of those three for kind of all of the rapid rehousing. Is HUD Greensboro going to come and monitor us for ESG? At some point, probably. So this is our chance to sort of take a look at this and see, hey, what are the things on here that we need to tighten up and clean up? Nobody's perfect. And it's important to keep in mind, this was over $2 million to spend in 2 years, and with a whole new set of rules and regulations. And keep in mind, annual allocation of ESG funds from the federal government to Durham is in the neighborhood of 175,000. So you essentially said, here's 10 years worth, a little over 10 years worth of ESG money, spend it in 2 years, and there's a whole bunch of new rules and create new policies, procedures, and forms and make sure they line up. So from what we heard from HUD is a lot of these are happening in all of their findings across the country. It's a lot of this administrative stuff that, you know, you rush a process, you're not going to get it all done when you don't have a capacity to do it. And it seems to be a consistent theme that I'm hearing. Good question, Ryan. But yeah, we will be looking to go out, and we will be getting back into monitoring all of our projects. We've just been hampered due to COVID and short-staffed.
Any other questions for Colin? Okay, thank you, Colin, for letting us know about those findings and the work that you're continuing to do. We appreciate all of your hard work.
Thanks.
Okay. The next thing on our agenda is a special NOFO update. And Lloyd?
Good afternoon. On February 7th, HUD announced awards of $315 million for the special NOFO competition that HUD conducted with us in last year, kind of concurrently with the annual continuum of care competition. You recall we were eligible to apply for over $2 million to address unsheltered homelessness within our COC. Unfortunately, Durham was not funded in the competition or in the award announcement that HUD made earlier in February. We can congratulate the Balance of State Continuum of Care, which Ryan's organization, the North Carolina Coalition to End Homelessness, is the COC lead agency for the Balance of State, and they received an award of nearly $22 million to be spent over 3 years to address rural and unsheltered homelessness in the 79 counties across the Balance of State COC, and also the Northwest North Carolina COC up in the northwest part of the state got a smaller award of $446,000 as well to address rural homelessness in that continuum. HUD did say in their announcement that in the coming weeks they'll be awarding grants to an additional set of communities, as well as allocating housing vouchers to awarded communities. The initial special competition was for $322 million to be available. They announced awards of $315 million, so they've not yet made $7 million worth of awards. So there's an outside chance Durham could still get some funding from this, but probably not likely. But HUD was kind of opaque in terms of what it said, but wanted to bring you up to date, and certainly we congratulate Ryan. Hopefully that award will help a lot of unsheltered and homeless people in the rural parts of the state, and perhaps reduce the incentive perhaps for some homeless people to come to more urban areas of the state to seek services.
Thank you, Lloyd. Does anyone have any questions for Lloyd? We congratulate the Balance of State for their award. We will move on to the final items on our agenda. And that's the call for new standing committee members and the call for COC liaisons. Our COC governance charter delegates some HSAC responsibilities to standing committees, and those for us are performance management and policy and planning. There is a required 3-to-1 ratio, 3 HSAC members to 1 COC liaison for these committees. I was not able to get the updated count prior to our meeting today. However, the last totals I had for, and Jonathan, you can correct me if I have this wrong, or Colin or Melissa. The last numbers I have for performance management were 5 HSAC members and 3 COC liaisons, which would mean we need 4 more HSAC members on the performance management committee to make that 3-to-1 ratio. So we were really looking for some people, HSAC members, to step up and join that committee. Our policy and planning had 8 HSAC members and 2 COC liaisons. And so right now we have the 3-to-1, a little bit more on the a little bit heavier on the HSAC side. So if we had 1 more HSAC, we could take 1 more COC liaison, if that makes sense. So to maintain that 3-to-1 ratio. So policy and planning is okay right now, but we're always willing to accept more people who want to be involved in these subcommittees. So we certainly won't turn you away, but we really need some HSAC members to join these committees, because one thing for doing that, it gives our COC liaisons more opportunity to also participate. So we would really love to have more of our HSAC members to join one or the other of those committees. But I think especially performance management, we need your assistance on that so that we can get that ratio of 3-to-1 up to speed. If you are interested in joining either of these committees, then email Durham Opening Doors at durhamnc.gov and let us know so that we can get you assigned. Let's see here. We are actually, can you believe it? It is only 4:15 and we have been through the agenda. Do you believe it? We're finishing early today. It's amazing. So I will ask, because I don't usually get to ask this, do we have any announcements that anyone would like to make? We usually don't have time to do that. You weren't ready because you didn't think we were going to have time to do it, so you didn't bring any. Okay. But thank you all for being here today. I wish you the best. I will take a motion to adjourn this meeting. Be sure you say who you are when you make your motion or your second.
I'll make a motion to adjourn. This is Angela Holmes.
You. Second.
I'll second. This is Eliza Matthew.
Thank you, Eliza. All in favor of adjourning, you're welcome to leave. Have a wonderful week. We will meet again next month.